Indications. CABOMETYX, cabozantinib, is indicated for the treatment of adult and pediatric patients 12 years of age and older with previously treated unresectable, locally advanced or metastatic well-differentiated pancreatic neuroendocrine tumors, PNET. CABOMETYX is indicated for the treatment of adult and pediatric patients 12 years of age and older with previously treated unresectable, locally advanced or metastatic, well-differentiated extrapancreatic neuroendocrine tumors, EPNET. Select important safety information. The full prescribing information for CABOMETYX includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar plantar erythrodysesthesia, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hi, I'm Dr. Sandy Kotiah, a medical oncologist and director of the Neuroendocrine Tumor Center at Mercy Medical Center in Baltimore, Maryland.
And I'm Dr. Katharine Thomas, a medical oncologist at the Pennington Cancer Institute in Reno, Nevada, and assistant professor of medicine at the University of Nevada, Reno.
Welcome to CABOMETYX in Conversation. Today, we'll focus on neuroendocrine tumors, or NETs, located in the GI tract. In this video, we'll be discussing Caitlin, a hypothetical patient diagnosed with a small bowel neuroendocrine tumor. Dr. Thomas, let's look at her case. Caitlin is a 63-year-old woman with no significant past medical history or comorbidities. She's a non-smoker with limited alcohol use. Her symptoms include frequent abdominal discomfort, sleep-disturbing diarrhea, weight loss, fatigue, and worsening back pain at night. Her imaging revealed an enlarged liver, thickening of the distal ileum, and lesions in the hepatic lobes, as well as her ribs. She was referred for a colonoscopy where a prominent ileocecal valve lesion was detected and biopsies were taken. Lab results showed a moderately elevated 24-hour urine 5-HIA level and a Ki-67 index of 4%, and her dotatate PET scan was positive. She was diagnosed with a well-differentiated grade 2 somatostatin receptor positive functional neuroendocrine tumor of the small bowel. Dr. Thomas, after reviewing Caitlin's case, what stands out to you about her condition?
Well, I think Caitlin's case is a good example of a patient that I might encounter. No significant past medical history, yet she presents with flushing, diarrhea, and abdominal discomfort. These symptoms are likely due to her functional tumor disease caused by excessive serotonin production. What also stands out to me is her grade 2 tumor. Neuroendocrine tumors are heterogeneous and their behavior can vary. Even grade 2 tumors like Caitlin's can present with diverse patterns. Some may be slow growing and asymptomatic, while others may behave more aggressively. This variability is why grading alone may not fully predict how neuroendocrine tumors will behave, so it's critical to monitor them over time. What about you, Dr. Kotiah? Any thoughts?
Thanks, Dr. Thomas. I agree. Caitlin's case indeed highlights the complexity of neuroendocrine tumors. For optimal patient care, I take a comprehensive approach. This includes biomarker assessment, as well as regular imaging and ongoing symptom management, as well as tumor control. I'm curious, how would you navigate Caitlin's treatment plan?
When guiding treatment decisions for patients with neuroendocrine tumors, I prioritize several factors, including 5-HIAA testing, tumor differentiation, grade, and somatostatin receptor status. Because each patient has a unique clinical scenario, considering these aspects helps inform the disease behavior and potential response to treatment. Furthermore, given the current approved therapies available, choosing the most appropriate treatment for your patient is critical. In some cases, a referral to a NET center may be considered for patients who require multidisciplinary review of their case. I also like to focus on the patient situation, consider their performance status and anticipated response to treatment. A patient's personal preference may also impact treatment decision, especially for someone like Caitlin who lives in a more rural area and must travel a longer distance for appointments. In Caitlin's case, she started on an initial treatment but experienced disease progression in the liver, bones, and lymph nodes over 24 months. Given her overall profile and the fact that she has functional disease, I would prefer to use a therapy that's approved in patients with functional disease. I would consider Caitlin as an appropriate candidate for CABOMETYX with a concurrent SSA treatment to help manage her hormone production.
Thank you, Dr. Thomas. I agree with your assessment. Now let's take a look at the CABINET trial design. The CABINET trial is the first phase 3 study to encompass the wide range heterogeneity of neuroendocrine tumors. The NCI-sponsored trial enrolled 2 independent cohorts that evaluate patients with pancreatic and extrapancreatic neuroendocrine tumors. Patients were required to progress or have intolerance following an FDA-approved systemic therapy, not including a somatostatin analog. Patients were randomly assigned to either CABOMETYX or placebo, and eligible patients in the placebo group who experienced disease progression were allowed to cross over to CABOMETYX. The trial's primary endpoint was progression-free survival, or PFS, and secondary endpoints were overall response rate and overall survival. 1/3 of the patients had tumors in the GI tract, including small bowel, rectum, stomach, cecum, and appendix. About 70% of the patients in the EPNET cohort had grade 2 or 3 tumors. Additionally, the trial included patients with functional disease, and many patients received concurrent somatostatin analogs. Dr. Thomas, what are your thoughts on the CABINET trial design?
I appreciate that the trial studied a diverse group of patients, including those with functional disease, grade 2 or 3 tumors, and prior PRRT treatment. This is particularly relevant to me, as many of my patients have similar backgrounds. It's reassuring to know CABOMETYX has been tested in a patient population that's reflective of the real world.
Great points, Dr. Thomas. With that context in mind, let's now dive into the efficacy data and see how CABOMETYX performed. Looking at the results, it's encouraging to see that in the EPNET cohort, CABOMETYX doubled median progression-free survival versus placebo. How compelling is this data for you, Dr. Thomas?
The data is quite compelling for me. CABOMETYX showed a significant improvement in PFS, 8.5 months versus 4.2 months, than those receiving placebo, which is a 60% reduction in the risk of progression or death. I also find it helpful to see the data evaluating PFS across key patient subgroups. However, they're not powered to show differences between arms, and results should only be considered hypothesis generating.
Thank you for your insight, but of course, efficacy is only part of the picture. Safety is equally important when considering treatment options. Let's take a closer look at the safety profile of CABOMETYX in terms of tolerability for patients in the EPNET cohort. As far as the safety data, the top 5 most common adverse reactions in the EPNET cohort for CABOMETYX were fatigue at 73% compared to 58% in the placebo group, diarrhea at 65% versus 42%, hypertension at 64% versus 37%, rash at 50% versus 10%, and stomatitis at 40% versus 10%. Dr. Thomas, what are your thoughts on these safety findings, and how do you handle these adverse reactions?
I think the safety profile observed in the CABINET trial aligns with what we know about CABOMETYX, and importantly, no new safety signals were identified. As mentioned earlier, it's worth noting that CABINET included patients with functional disease, as hormone production can cause additional symptoms. I also look at lab abnormalities and liver function, especially AST and ALT levels, particularly in patients with liver metastases. It's important to have strategies on how to help manage these adverse reactions. For eating and swallowing and digestive issues, I work closely with a nutritionist. They can help manage pancreatic enzyme levels and nutrient absorption, which may prevent weight loss. Fatigue is another challenge. While there's no quick fix, I encourage hydration, sleep hygiene, regular exercise, and balanced meals. For nausea, I'm more proactive, using a set regimen of antiemetics and adjusting as needed to minimize its impact on patients' lives.
I completely agree. I have noticed that patients with small bowel NET and high liver burden struggle with indigestion and weight loss. I find that working closely with a nutritionist is key to helping manage these debilitating symptoms. Fatigue is always challenging, but encouraging patients to listen to their bodies is crucial. I also like to point out that not all adverse reactions can be managed, and some may require dose modifications or even lead to permanent discontinuation.
I share similar thoughts. When initiating therapy, the recommended starting dose of CABOMETYX for adult and pediatric patients 12 years of age or older who weigh 40 kilograms or more is 60 milligrams once daily, and the recommended starting dose for pediatric patients 12 years of age or older and who weigh less than 40 kilograms is 40 milligrams. I also find it helpful to know that 38% of patients in the EPNET cohort required dose adjustments due to adverse reactions. It's reassuring to know that CABOMETYX demonstrated efficacy even with those dose reductions. Additionally, the package inserts guidance on dose modifications for specific adverse reactions strengthens my confidence in using CABOMETYX.
Great, thank you, Dr. Thomas. I also think it's worth mentioning that Exelixis offers a great patient support program called Be Connected. Programs like this, which provide educational support for both patients and caregivers, can be very helpful, and I encourage my patients to join the program when initiating CABOMETYX. Another important program to highlight is EASE, which stands for Exelixis Access Services. It offers a variety of access support to meet the unique needs of eligible patients. Terms and conditions may apply. Dr. Thomas, as we wrap up today's discussion on CABOMETYX in conversation, do you have any other final thoughts or advice for oncologists?
Sure. To wrap up, it's important to note that the CABINET trial included a broad range of patients with neuroendocrine tumors, covering various sites of origin, functional disease, metastatic sites, and tumor grades 1, 2, and 3. This study was representative of real-world patients reflecting the complexity we often see with this disease. This broad inclusion supports the use of CABOMETYX in previously treated, unresectable, locally advanced or metastatic, well-differentiated neuroendocrine tumors. The trial's inclusive design and significant PFS improvement gives me confidence in its applicability for treating GI NETs with various presentations. As for advice, I would encourage collaboration with other specialists, empower patients with education, and always remember that stability is a win. As oncologists, our goal is to make a positive impact on the patient's disease.
I couldn't agree more. Thank you so much for your time, Dr. Thomas. And thank you all for joining us today. Be sure to watch the other NET videos in the CABOMETYX in Conversation series.
Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Pediatric use. Physial widening has been observed in children with open growth plates when treated with CABOMETYX. Physial and longitudinal growth monitoring is recommended in children 12 years and older with open growth plates. Consider interrupting or discontinuing CABOMETYX if abnormalities occur. The safety and effectiveness of CABOMETYX in pediatric patients less than 12 years of age have not been established. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.